All right. Good evening, everybody. Welcome to another amazing Woo You event. We'll just give everybody a moment to make their way in and get here. And Dr. Murphy, you just finished patient care, right?
I just finished in the nick
Right in
of
the nick of
time.
time. So everyone's making their way, whether it be they're coming home from seeing patients or literally just seeing patients, and you just made your way in or on their way home. We're really excited to be here tonight, and I will get started because I know we have a lot of great information to cover. I know people are still making their way in, but welcome to tonight's Wu University event, Navigating Refractive Surgery and Patient Selection with Dr. Amir Morafi. I'm your host, Dr. Jennifer Stewart, and thanks to Zeiss for exhibiting at tonight's event. So just some reminders: for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be delivered within 4 weeks. Ask questions using the Zoom on-screen floating panel. So there are some case studies throughout the presentation, and since he can't hear your answers, he's going to be asking for some responses in the chat. So be paying attention. We're going to have some cases and ask you to share your opinions, but since we can't do it verbally, be ready to put those answers in the chat so we can make this an interactive event. So if you're on a mobile device, here's where you can find chat and Q&A. So it's my great pleasure to introduce tonight Dr. Amira Marafi is a fellowship-trained and board-certified ophthalmologist specializing in cataract surgery, vision correction, and anterior segment surgery. As a highly acclaimed ophthalmologist, he has made a positive global impact during his career. He completed a prestigious refractive surgery fellowship at the Cleveland Eye Clinic, considered the top fellowship in the country, with a focus on cataract surgery, advanced technology lens implants, implantable contact lenses, clear lens exchange, and other delicate procedures. His work has led to numerous publications and prominent peer-reviewed publications. He's also published numerous textbook chapters in the field of laser vision surgery and ophthalmic immunology. He completed his residency in ophthalmology at the prestigious Case Western University Hospitals, and completed his medical internship at UC Irvine Medical Center and the Long Beach Veterans Hospital. He earned his Doctor of Medicine degree from Chicago Medical School after completing 2 master's degrees in biomedical sciences and healthcare management and administration. He's always been eager and excited to provide the latest advancements and technologies to his patients. He's been amongst the first and youngest surgeons in the country to implant various technologies in his patients' eyes. Named by Los Angeles Magazine as a top ophthalmologist 4 years in a row, and is consistently recognized as a Southern California super doctor. Dr. Marafi has been quoted and interviewed by major publications such as NPR, NBC Nightly News, WebMD, Medscape, and Fox News for his humanitarian work here in Los Angeles. Welcome to Woo You. We're really excited to have you.
Wow. Thank you so much. Quite an introduction. I just want to first start off by saying it's a tremendous honor to be here. Thank you, Dr. Stewart, for that really
You're
kind
welcome.
introduction. I'm blushing, but it opportunities like this, whenever they come around, are super important to me. The collegial aspect of working together in these environments and teaching each other. I learned so much from my OD colleagues, and I love the opportunity to be able to teach on the other end. So much of my training was from ODs that were in a refractive surgery practice, so I feel like I owe a lot to the optometric community for who I am today. So this is a great honor. I have no financial disclosures, and we're just going to kick off and just going in. What are we going to learn today? So we really want to learn how we're going to navigate refractive surgery patients. So, let's understand the different types of techniques. We know LASIK is kind of like the gold standard. Everyone's heard of it. PRK was kind of like the original, and now we have a procedure called SMILE. We've heard of ICL. ICL's advanced recently, and what's kind of been building a little bit of steam lately is RLE, or what we consider refractive lens exchange, or clear lens exchange, or what some people would say like cataract surgery before the cataracts. So what we really want to do today is what patient factors influence surgical candidacy, like which patient would be best for which procedure. We have so many now. So, and we're going to do a couple of case studies and interactive discussions. Hopefully, this will help us get some real world experience. So, let's just quickly go over the options in refractive surgery. LASIK, we know the recovery is fast. Uh, who are the ideal candidates? Well, the ideal candidates are those low to moderate myopes for sure, including astigmatism. Hyperopia does work well. You don't want to be treating too much more severe or moderate to severe hyperopia. Those tend to have less than ideal outcomes. But LASIK is known for its dry eye risks. And of course, because we have a flap, we want to make sure that there's no flap complications. So a lot of times after LASIK, we do counsel on not touching the eyes. We'll get into that a little bit. And then let's talk about PRK. Well, I like to say the recovery with PRK is long. And that first week, you're not going to like me very much because you're going to be in a little bit of discomfort. That's why we use bandage contact lenses. But even with them, there's still a little bit of discomfort that our patients would feel. So it is something that is important to counsel. And the ideal candidates are more of those thin or irregular corneas or certain corneas that may have had scarring or past infections where maybe a femtosecond laser can't get through that scar to create a flap. So PRK is still, even though very seldomly used today, still important in our toolkit to use every now and then. And since 2017, we've been introduced to SMILE. And SMILE stands for Small Incision Lenticular Extraction. And it is kind of like that next generation LASIK, where we get to have the same type of results as LASIK, but without the flap. And because we aren't using a 270-degree flap to create an area for an excimer laser to treat, the femtosecond creates a double pass that cuts out a convex shaped lenticule analogous to the glasses prescription. By making a small 60-degree incision, we are preserving greater than 80% of corneal nerves, so there's a significantly lower incidence of dry eyes associated with SMILE. And because there's no flap, we don't have to deal with any of those flap complications, which I'm sure both of us love. So the ideal candidates again are those dry eye patients, mild to moderate myopia, and those athletes or those stunt doubles that come in from down the street in Hollywood who are at risk of potentially having flap complications. Our next option is ICL, which stands for implantable collamer lens. And ICL also has a really fast recovery, but it is intraocular. So we really reserve these for our really high myopes, really thin corneas, or patients who don't want to have any corneal-based procedure. There is a slight infection risk because it is intraocular, although that risk is very, very low. And in the older generation of ICLs, there was a risk of increased intraocular pressure and formation of cataracts. But with the new designs, with having little ports to allow fluid flow, those risks have significantly reduced, and in some studies have reduced down to zero. So the monitoring is still there, but we feel a lot better about it. And kind of like the last option, and mostly for our presbyopic and high hyperopic population, is the RLE, refractive lens exchange. It also has a fast, sometimes moderate recovery, but it does tend to have a higher cost and it does have that invasive nature. So let's keep going. And at any time, if anybody has any questions, please don't hesitate to just, shoot them out and I'm happy to answer them. So I'm sure everybody knows this. This is all kind of common knowledge, but let's just go quickly through LASIK. Traditionally, we use the microkeratome, a blade to create the flap. Now, more commonly, we use a femtosecond laser. And this creates a corneal flap, and that opens up the cornea to allow the stroma to be shown. And then we use the excimer laser to reshape the cornea to allow it to be the same as your glasses and contacts. Again, low to moderate myopia and astigmatism works phenomenal. Hyperopia also works pretty well. Quick recovery, very minimal discomfort. I have had LASIK myself. But you really just want to watch out for those thin corneas and patients who are predisposed or who already have dry eyes. And then we have our PRK, and PRK is our surface-based ablation, where we use a well or some sort of instrument to soften up that corneal epithelium to expose the stroma, and then we laser. Same exact results as LASIK. However, of course, just that 4 to 6 weeks of recovery, that initial week of discomfort, and there is a small risk of haze for which we use a medicine called mitomycin C, which greatly diminishes that risk. But there's no flaps, and for a long time, military or Navy or anybody who wanted to get laser vision correction were required to get PRK so they didn't have a flap. So there are some pros. And now we get into Smile, and Smile is that little lenticular removal. It does have a smaller approved treatment setting. So it only treats between -1 and -10, and a small amount of cylinder as well, from -0.75 to -3. So it can't treat a wide range like LASIK can. So it has a smaller subset of patients that are approved for it. But when they are approved for it, they do amazing. And it is beautiful procedure. Patients feel like they've recovered faster, they have less issues. And just be careful because it's very hard to tell anything was done if you look at their eyes the next day because you have such a small incision. So make sure you always ask your patients if you've ever had it. Topography will show it though. And then an ICL. And so this is a picture of me implanting an ICL into my optometrist who wasn't a good candidate for LASIK or PRK. But ICL is just this implantable lens that sits in between the iris and the natural lens. It's a reversible procedure, meaning there's no corneal reshaping. So at any moment, we can go in there and remove that ICL, and the patient will go back to normal. It's ideal for those higher myopes, thin corneas, or the dry eye is too significant for us to do any corneal-based procedures. We do have to monitor these patients, just have to make sure that the ICL sits at a perfect vault above the lens and also below the cornea. We want it to sit in a very specific position. So we have to monitor for that. And RLE is the same as cataract surgery, same exact procedure, except patients are usually younger, early 40s to mid 50s. These patients, they don't want to wear glasses, they don't want to wear reading glasses, they don't want to do monovision. RLE, we can use an advanced technology lens, a trifocal or an extended depth of focus lens that allows them to see distance and near without any glasses correction. These are the highest technology options for patients who are in this presbyopic age. However, they're also not perfect, so there are some limitations that are important to kind of go over with our patients. It is a more invasive procedure. It does have a slightly higher cost, but it is permanent to the degree of no refractive changes should occur since our natural lens is no longer there. And what are the key factors that we look for in patient selection? So age. So if a patient is younger versus an older presbyopic patient, this changes the analysis of how we approach certain patients. If a younger patient comes in, we're definitely not talking RLE. But we also want to keep in mind, hey, if the patient is really young, is their refraction stable? Is there less than a half a diopter of change over the last 2 years? A 19-year-old patient may still have some prescription changes, so this is important in counseling. And a procedure like SMILE can only be done one time. So these are important things to counsel. Even though it works well, and even though we target a more hyperopic target for our younger patients, these things all need to be looked at. You treat a 19-year-old patient different than you treat a 29-year-old patient versus you treat a 39-year-old patient. So these are all things that we need to look at. What is the refractive error? Is it myopia, astigmatism, hyperopia? Well, a patient who is hyperopic who wants SMILE, we're not FDA approved for that here. So that's not an option for them. So we have to look at the different treatments that they have, their prescription, and then choose a procedure based on that as well. And of course, we always look at corneal thickness. Having a thin cornea does not mean you're not a good candidate, but we have to look at the corneal thickness along with the prescription. A thinner cornea with a mild prescription may still be excellent for LASIK or SMILE. Doesn't have to go to PRK, but a stronger prescription may put PRK on the map, or the idea of doing an ICL becomes um, more of a better option for some of these patients. Thick corneas, those are great. We love them. But one thing we always have to watch out for, if you see a cornea that's above 600 microns or 650, even if they're young, I always check at the slit lamp for any gutata or guttae and make sure that there isn't any sign of Fuchs dystrophy because that can cause corneas to swell up and get thicker. So just always make sure thick corneas, we love them, but we always verify that it's not thick for a pathologic reason. And irregularity. We love seeing symmetry on the topography. If there's any irregularity, that should give us some pause about our treatment options, if we should even do anything on the corneal plane. So make sure you look at the cornea as well. And then medical history, like dry eye, we really want to watch out. The overwhelming majority of patients who have chronic dry eye have never had LASIK. But there are some patients who are predisposed to getting dry eyes who get LASIK and the dry eyes come on faster. So it's really important that we do our medical history, family history, usually patients with history of autoimmune conditions, lupus, rheumatoid arthritis, MS, things of that nature will be more likely predisposed to dry eyes. And if there's any family history, we have an opportunity to counsel them and prepare them. If a patient is adequately counseled, adequately prepared, and there's no surprises, they tend to do a lot better if they're like, I know that I'm at a higher risk of dry eyes, and I'm still okay with moving forward, versus, hey, you never told me this. Then they feel abandoned and they don't feel cared for. So doing a very thorough history is important. Age as well. Um, People, as we get more birthdays, we tend to get more dry. So this is something that we also have to keep in mind. I do like the idea of using Smile for my older patients. That is a good option to look at. So take a look at all the different aspects. So, and then I kind of touched on this already. Watch out for any contraindications, anything like prior HSV infections in the cornea, any autoimmune conditions that are active, anything that we have to be mindful of that may result in an unwanted outcome. So these are very key factors, and these are key factors that both the OD and the MD play in this because we are both eye care providers and we both have to look at the history. And so big red flags. Obviously, any type of keratoconus, pellucid marginal degeneration, these are things that we don't want to touch the cornea. We want to refer them for cross-linking or any other type of procedures that can stabilize the cornea from getting worse. Irregular corneas, you want to make sure that you take a moment and take a look at it. You want to see that, hey, is this from overuse of contact lenses? Is their cornea dry? And irregular topography requires an understanding of why. And if it is irregular, then you should counsel the patients because they would have a slightly higher risk of developing post-LASIK ectasia or post-refractive surgery ectasia. And it's important for them to know that so they feel informed and then they can make a decision on their own. Ocular surface disease. I mean, we live in Southern California. It's an arid climate here. Everybody has some degree of dry eyes here. So it's super important and a very big part of our counseling is talking about dry eyes. And not just the fact that you're going to get it, but how to treat it, how to prevent it, what measures we can take, showing our patients how to use drops, talking about plugs and other treatment modalities that are available if they ever need it. But the most important thing that we always have to talk about is those unrealistic expectations. A lot of our patients want to sometimes come in and see through walls and see things this close and that far, and we have to be able to counsel our patients and we have to be able to say no. This is super important. Sometimes we feel pressured by our patients and we try to give them something that we know we can't, and that's just going down a rabbit hole that we don't need to go. If somebody feels like their expectations are like, well, I have a -9, I don't want any dry eye, I don't want any halo at night, and I want to be able to see everything for the rest of my life and never need to do anything again. This is an opportunity to say no. I don't think you're a good candidate. What you're expecting is not realistic. This is a very important attribute that all of us must have within us. We all have it here and there, but there's always that one patient that gets us, and it still happens to me every now and then where you start to say things that are like, wait a minute, time out. No, 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 no. We cannot do these things for you. So very important things to look out for here. And let me just see real quick. I think I got a couple questions. So let me address some questions and then we'll start to go through some of our case studies. So how long do you tell a patient when asked how long PRK and they can go back to work, drive, etc.? So I tend to be a little bit on the longer side where I will tell my patients, hey, expect to not be able to function, have good functional vision in that eye for 4 and sometimes up to 6 weeks. That way, if they start to see better after 2 weeks, they feel like, wow, everything is perfect. Um, but if you tell them 2 weeks and they're still not comfortable, then they feel like something is wrong. And so I generally tend to say, hey, you know what? 4 to 6 weeks is what's expected. I have seen some patients heal up within 2 to 3 weeks, but I would just prepare for 4 to 6 weeks. It allows them to be prepared. You never want them, you never want to, what is it? Under promise, over deliver. So, um, what is TPRK? I'm not sure what TPRK is in this scenario. And okay, we have a question of how is the ICL sutured in the eye? So ICL is actually not sutured in the eye at all. The ICL has little foot plates. Let me see if I have a model. No, I don't have one. Has little foot plates, and the foot plates tuck in nicely underneath the iris and sit right in between the iris and the lens. So it's a sutureless procedure. Is dry eyes permanent after LASIK? Excellent question. We get this question asked all the time. Thank you for asking this. Um, Dry eyes theoretically and pathohistologically is not permanent after LASIK. So when we create a flap with LASIK, we are cutting 270 degrees of corneal nerves. And these are peripheral nerves. They're not cranial nerves. As we know, peripheral nerves do regenerate, and they usually take 3 to 4 months for them to regenerate. So typically the dry eyes that you get with LASIK is temporary. However, like I said, there are some patients who are predisposed to having chronic dry eyes, even if they never got LASIK to begin with. But it's sometimes the LASIK brings on the dryness a little bit sooner for them. So they think, hey, it's the LASIK that caused my dry eyes. All right. And so with ICL, where do we currently stand for toric correction? So the range, I think it goes up to a -4 diopter of toric correction with the ICL. And I think it's the least amount is -0.75. Is there any level of glutatic contrast? Yeah, yes, great question again. So yeah, you definitely want to make sure you want to look at the cell density count. Anything less than 2,000 should bring some concern. Anything less than 1,500 endocell count, you also want to make sure that you probably would want to avoid doing this procedure. And then I'm going to hold off on the questions until the end. We'll do some more questions there, but these are awesome questions. Please keep them coming because I'm sure if you're thinking it, other people are thinking it as well. And it also challenges me to dig deep into my knowledge base to answer these. So let me put this to the side. So let's start here. Case one. Uh, this is our typical bread and butter patient coming in, 27-year-old. He's got some mild myopia, -250 in both eyes. Overall, no ocular systemic health issues. He feels his eyes are dry at the end of the day when he wears contacts, but he feels fine in his glasses. He's got some pretty average corneal thickness, 541 and 537 microns. His topography looks regular. And his mesopic pupil is 6.4 millimeters. As you guys know, the most common treatment diameter that we use for LASIK is 6.5 millimeters. So when a pupil tends to be less than that, it does have a protective effect against halo and glare, where larger pupils, especially above 7 millimeters, do have a higher incidence of halo glare because we are letting a lot more peripheral light come in from the cornea. His hobbies are baking and competitive jiu-jitsu. So interesting. So what procedures would you recommend and why? And this is something, there's no wrong answers. If you go with LASIK, that's fine. If you go with SMILE, that's fine. PRK is an option. There is no wrong answer here, but justify to yourself, what would you do? If I always ask myself this question, and it seems to always lead me the right way. If this was my little brother, what would I pick for him? Well, he is a myope. He's a little myope. Does have some dry eyes, but it's not anything serious. I'm not seeing any signs on the exam. But he loves competitive jujitsu. So that means this guy likes to go out there and go into competitions. For me, the competitive jujitsu and the little bit of dryness makes me lean more towards Smile because one, he doesn't have to worry about the flap, and I'm not going to be too worried about aggravating his dry eye symptoms with the Smile procedure. So for me, this one I would go with Smile, quick recovery, limited dry eye issues, and no flap for his jujitsu. Now we have our 46-year-old aspiring professional pickleball player. He's coming in. He's like, Doc, I've had perfect vision my whole life, and then one day I turned 40. I woke up one day and I just couldn't see near, and now it's getting harder for me to see the pickleball, and it's really hard for me because I can't wear my glasses when I play pickleball because they bother me, and so what can I do? Well, can I get LASIK? Well, plus two, he's a good candidate for LASIK, but we have to acknowledge his age. He's 46. He is well into the early stages of presbyopia, if not into the middle stages of presbyopia, where he does notice a significant loss of near vision, especially if he's not wearing his glasses. So he's got thick corneas, well, that's great, regular topography, and he's got small pupils. So, I mean, laser vision correction on his cornea is not a bad option, but will it give him what he needs? So his two options are here. Like if he wants to be able to see far and near without glasses, if we do go with LASIK, we would have to employ monovision. And where would we employ monovision? Would it be more of a one eye distance, one eye intermediate, one eye distance, one eye near? We have to counsel him on monovision. Well, one of the things we worry about with monovision is taking away depth perception. When we don't have two eyes staring at that speeding pickleball coming at you, you may lose the ability for that depth perception where he may miss and swing. If he's trying to be a professional pickleball player, we don't want to lower his game. Well, we can go with both eyes perfect for distance, but that does not solve his near vision issue. So we are still kind of not really giving him exactly what he wants. He wants a glasses free life so he could be the best at playing pickleball. So, given that a natural lens in the eye continues to change every year, a thin sheet of protein is laid on the outer layer of our lens, and that's what causes our lens to get ever so slightly thicker and thicker and thicker until around the age of 43, where our ciliary muscle cannot pull the zonular fibers strong enough to accommodate our lens. His lens is kind of well into the point where it's not able to accommodate. He used to say I had perfect vision, so he was constantly accommodating through his plus two prescription. I'm thinking for this guy, he needs distance, he needs near, he's a hyperope. Even though everything else looks good, he, in my opinion, I would be recommending RLE. Why or why not? Well, why? Let's go through the why. Why? Because with the RLE, I can put in a trifocal lens that'll give him distance, intermediate, and near vision. So he will get his range of vision so he can see up close, he can see far. It'll be a permanent procedure and we will solve majority of what his problems are. Now, just because you get an RLE does not mean you become 100% glasses free. I always counsel my patients that you will get near vision at about 12 to 14 inches, intermediate vision, which would be about arm's length, which is like computers, car dash, GPS, prices at the grocery store, and far. If you want to look at anything closer, you will need a light pair of reading glasses. If you wanted to read the really fine print on the back of a prescription pill bottle or eye drop bottle, you may still need to wear a light pair of glasses or take a picture with your cell phone and zoom it in. Also with RLE, sometimes people think they get supervision. They could see in the dark, they could see, through walls. So I always counsel if you're going to a nice romantic restaurant, it's like a candlelit restaurant, and it's dark inside, you may still need to use your cell phone light or the candle to read the menu. So just keep that in mind. And the other thing is that trifocal lenses do have optical rings on the optic of the lens. And because of the rings, the different rings portend to different distances. Because you do have these rings, you will notice a little bit of glare or halo around lights, especially at nighttime. Now, they do expect that about 90% of patients will get used to or stop noticing these halos or glare, but about 10% of patients will always notice it. Now, 1 out of 10 patients noticing it is a significant number. So do counsel them. And there's vision simulators and there's different types of apps that you can use where you can show your patient what the halo and glare looks like. So these are very important things. Why not? It would be if this person who loves to do a lot of nighttime driving doesn't want to have those rings around the lights. He's a pilot or he's a truck driver, and there's a lot of nighttime driving. Those are patients where you may not want to do RLE. The other one is that he still has some degree of accommodation. Do we want to take away his natural lens all the way, like right away, or should we make him wait a little bit? In this particular case, this lifestyle choice he's making is for his desire to be a professional player. So for me, it makes sense to do it. But there's no right or wrong answer. There's many different ways that we can do it. So I like the idea that it's permanent. It'll correct his hyperopia and his presbyopia all in one. All right. So here's our next patient. He is a 33-year-old in RGP contact lenses. He's a minus 950 in both eyes. Otherwise, his eyes are perfect. Um, Thinner packies, not super thin, about half a standard deviation thinner than average, but a very strong prescription. So, keep that in mind. His topography is an example of it is listed on the right. It looks pretty regular, nothing too crazy. And he does have a slightly larger pupil. And he looks very happy to show us his contact lens in the photo, but he's really here because he doesn't want to wear it anymore. He's happy because he's not wearing it, even though he can't see. What are his hobbies? He likes to watch sports and go to movies. So, what are we thinking here? What's the best option? Um, if we did LASIK, we could do LASIK. He does have thinner cornea, so we do have to be very mindful of thinning out the cornea too much. So that's one thing. But additionally, when we are ablating a minus 950, we are ablating the cornea to become more flat. He's nearsighted. He can see very close. His eyes are very strong. He needs a very strong minus lens to let him see distance. How do we make a cornea see better? We have to flatten it. And when we flatten it too much, it's the peripheral edge of the flattening that induces the halo and glare associated with refractive surgery. If he already has a larger pupil that goes beyond this peripheral edge and he already notices some halo and glare to begin with, this will only worsen his nighttime halos and glare. So I'm very mindful. I never want to put my patients in a situation where they're worse off. I always want them to be better off. And so when I see a patient with these parameters, I am for sure thinking ICL. ICL here will not touch the cornea. It'll treat the prescription. He's got the thin corneas that we don't have to touch. He's got the larger pupil size. He may still have issues with halo and glare at night. That's still important to talk about. He still has a larger than normal pupil, but it would not be worsened by doing refractive surgery on the cornea. And That's where ICL really helps. And here we are with another patient. These prescriptions are sometimes scary to look at. A 29-year-old, he's got plus 350, minus 375, and a plus 275, minus 425, and he's best corrected to about 2025. Uh, he does not like, he can't wear contacts. They just don't feel good, and his glasses feel heavy, and he doesn't like the way he looks in them. Well, he doesn't know what to do. He's not very happy. He's got slightly thinner corneas. We can see his topo. He's got some pretty steep astigmatism, but overall looks regular. Nothing that I'm worried about. Does have good sized pupil, and he loves playing video games and reading. So, what are the best options here? And so, you know, do we think PRK? PRK doesn't always work the best for hyperopic prescriptions because when the epithelial remodels at the top, we're making a hyperprolate cornea. If the epithelium fills in that gap, it can diminish the effects of the hyperopic treatment. So we tend not to like PRK so much for hyperopia, but it works well for astigmatism. Smile, we can't. It's just not within the parameters of smile. ICL, we can't. Well, what about RLE? Well, he's 29 years old. He still has a very high functioning lens. So I don't want to take that away. He hasn't lost any accommodation yet. So in this case, LASIK would be his best bet. Now, it is important to counsel him that his best corrected vision is 2025. Now, sometimes patients with these extreme prescriptions, I've seen them see 2020 after LASIK. But it is important to counsel that, hey, you should expect to see as well as you do with glasses than you would with LASIK. If they see better, great. That's a bonus. We look like heroes, but we don't want to say we think you'll see 2020 if we can't refract them to 2020. Um, the other thing is prescriptions like this do tend to have not the same longevity profile as our simple myopic astigmatism corrections for LASIK. So there may be a need for a touch up or an enhancement a little bit down the road. Maybe not right away, but maybe 7 to 10 years versus some of our other patients can go 15, 20 years. I will counsel my patients with that, and by having a LASIK flap, we can go back and lift it if we ever needed to, depending on the time frame. If it's too long, you generally don't want to lift it, but if it's not too long, you can consider lifting the LASIK flap and just re-ablating that same stromal bed area. Awesome. And so I can't emphasize enough the OD's role in refractive surgery. Where I trained in my fellowship, the ODs and the MDs had an extremely strong collaborative effort, which made for the best patient care. I currently, in my practice, have two amazing ODs who really do the most of the legwork. There are things that optometrists are better at than ophthalmologists. There are certain things that ophthalmologists can do that optometrists can't do. And if we work together in a collaborative fashion, we can provide the highest level care. And that's what this is all about. Refractive surgery patients are a different breed of patients. They tend to have a lot of fear, anxiety, higher expectations. They're paying out of pocket for a procedure. They're expecting a certain like outcome. And so what the ODs can do and what their skill sets are can really complement what the ophthalmologist can do. And this provides a very great unified approach towards providing the best possible care. I believe every laser vision center should be definitely run by optometrists and ophthalmologists. There should not just be one or the other. And the big things are the preoperative. RODs do a lot of our cycloplegic refractions. They screen the patients. They look for aspects of the exam that are, could be a red flag that we need to be, aware of, and counseling our patients, counseling on the options, talking about what's available. And any patient, when they hear something more than once, they feel more comfortable. When you hear something once, your brain doesn't know how to sort it. When you hear it for the second and even third time, especially from an eye care professional, you can get a lot more ease, a lot more relaxation, a lot more knowledgeable. And that is a very, very important step to success when it comes to collaborative care for refractive surgery patients. So, refractive surgery patients need to be educated like any other patient. Don't just because they're elective, just because they're paying out of pocket, does not mean that they shouldn't get that high level of care. And the ODs provide some of the best level of care, even better than the MDs most of the time. So very, very important. Post-operatively. So my ODs do almost all of my post-operative care, and they're amazing at it. They can find things and see things that, I can't even imagine finding. So they're really great at it, and they treat and the very, very low incidence of DLK, which stands for diffuse lamellar keratitis, rarely seen today, but was seen more so back in the day of microkeratome. But if it's there, how do we treat it? How do we not let it get anything worse? And how do you make the patient feel comfortable and secure when they are being treated for something like this? If there's a flap complication, how do they manage it? Do they not panic? They call me, I come in, we treat it as if it's something that's not a big deal, which it isn't. If you catch it early, it's usually very easily treatable. And then, managing dry eyes, monitoring the healing, giving our patients the awareness that they are being looked after. We have their back. And this collaboration is just the strong partnership and knowing that when my OD is a refractive patient, I have such confidence in their refractions and their ability to do an examination allows me to focus on the areas where I'm good at. And when everybody elevates at their specific expertise, this is when we can provide the highest quality care. So very important. Oops, sorry about that. So what are the key takeaways? So the most important thing, guys, is patient selection. All right. We're very fortunate to be in a busy enough practice where we can say no to our patients. We do not have to say yes to everybody just because they walk in the door. When patients are showing you red flags, be heed to those red flags. If they're constantly going against what you're saying or being forceful or expecting things that they can't, it's okay to say no. Sometimes they'll get angry. We're so used to trying to help and please patients that when somebody gets angry, we start to compromise what we believe in. But patient selection is by far the number one most important uh, takeaway for successful outcomes. Not just based on health, not just based on topography, pachymetry, prescription, but also managing expectations. Collaboration, that's number two. If you can find somebody to work with that respects each other on the same level, in my mind, in my fellowship, the OD was equally as important as the MD, and that is a healthy environment that fosters growth, success, and a collegiality. This is what we're doing. We're both taking on the role of taking on a patient. It doesn't matter where you are in the hierarchy, everybody plays an important role, and the ODs and MDs are equal when it comes to taking care of our patients. And honestly, my optometrists are so good at taking care of our patients that sometimes our patients think that the optometrist did their LASIK, and I'm okay with it. They're like, "Oh, like that was awesome. They did a great job," and I'm like, "That's awesome." That's the type of connection that you want. That's the kind of environment where you want, where it's like everybody deserves the praise and the success of our making our patients happy. And refractive surgery is a very, very successful surgery. We're very lucky to have such a beautiful procedure in our field. And when the ODs and the MDs utilize it in the right way, we can make patients very, very happy. And when we work together, that's when it works out the best.